Hello, I am Theresa Stack, an associate professor at Montana Tech, and this learning unit covers the anatomy and physiology of the spine. It's called the Human Spine and Work, and it goes along with chapter 13 of our text. So our learning objectives for this unit will be to review spinal anatomy, to understand how the physical workplace risk factors impact the spine, and this will enable you to combine biomechanics, spinal anatomy, as well as anthropometry when you're applying lifting assessment or postural analysis tools. There's a video that you probably would like to watch first, and the link is on Moodle as well as here for your viewing pleasure. So let's take a look at our human spine. When we take a look at our human spine, we should have this natural S shape to it, which means it's convexed, or it's concave, convexed, and concave again right down at the bottom. So you can see how your spinal vertebrae are smaller on top than they are in the bottom. Smaller on top than they are in the bottom because we support more weight on the bottom of our spine as opposed to the top of our spine. So this is our skull, and our first 7 vertebrae are cervical spine vertebrae. They're the most movable part of our spine and make up your spine starting from the base of your skull. Then you have T1 through T12. They make up the thoracic area of your spine, and they're the least mobile part of your spine. And one of the ways in which you can see that immobility is there's a lot of space between the spinal processes here for your C1, so your C12, C1 through C7. But your T1 through your T12, how they lay flat, that causes them to be immobile or somewhat fixed. And then your last vertebrae are your L1 through your L5, and these hold most of the weight and have some moderate forms of mobility. Then you'll have your sacral and your coccyx area. Your sacral area is 5 bones which are fused together, and your coccyx area is 4 bones which are fused on top of your 5 bones. And this is where your pelvis comes into contact with your spine. So these are your spinal vertebrae. In between each one of your spinal vertebrae, you have a spinal disc, which acts as your shock absorber. And then here again are your 2 spinal vertebrae. And the joint here is called your facet joint, and there's nerves that exit in between each one of these areas within your spine. So your vertebrae are very similar to children's building blocks, which are stacked on top of each other. You have fixed segments, which are your bones, and your movable connectors, which are your spinal discs and your ligaments. And again, your ligaments are that dense cartilage material or dense material that holds your spine in place and creates stability. Ligaments are bone to bone, where tendons are muscle to bone. Small bones project from the back and the outside corners of your spinal discs. These processes act as anchorage points for your tendons and your ligaments. And here you can see a cross section of the spine, and your spinal canal is in the center here, and your nerves would run through that. And then this is the area where your spinal disc would sit on top of. And here's a cross-sectional area of your facet joints. So in between each one of your spinal discs, or in between each one of your spinal vertebrae is your spinal disc. And your spinal disc is a cushion that is in between each one of your spinal vertebrae to absorb shock and to protect your spine from impact. The outer ring on your spinal disc is hard. If you think of it as, some people use the term like a jelly donut. This is the donut part, and then the jelly part is in the center, and that's the nucleus material. So the jelly is soft and gelatinous like the nucleus material, and the donut part is harder, and it keeps the nucleus material inside. And so this is the how outside is fibrous. The outer ring keeps the spinal disc in place. The inner ring or the nucleus is more gelatinous and it's hydrophilic, which means that nutrients and water are able to seep into the center through the outer ring, and waste products seep out. So it's considered hydrophilic, and that's the way material moves into and out of the spinal discs. You don't have any nerve endings inside of your spinal disc. And then your end plates are, of course, covered in cartilage. And we can take another look at your spine here and your spinal discs. We have some degenerative diseases in this area. The spinal vertebrae are starting to break down. Another thing to note, maybe not so important, is the misnomer between the term a slipped disc. You can't slip a disc. It has no place to go. It's attached to both the top and the bottom of the vertebrae. But you can slip a vertebrae or take a vertebrae out of alignment, and that can cause problems with the spinal disc that's in the inside. And when we look a little bit about the anatomy of the spinal disc or the shape, you can see that it's thicker in the front area, so it's thicker on the abdomen side and a little bit thinner in the back side or the spinal process area. So that means that when you flex forward, the nucleus moves towards the back and creates this slight bulge in the spinal disc. And so we have this thicker, denser material in the front, which restricts your extension or your back bending, but enables you to flex forward or curl forward with your spine. We're looking at a cross section here. You can see the rib cage and two nerves exit from each side of your spinal discs, and they pass through those openings. What I like about this picture is, although this isn't upper extremity musculoskeletal disorders, you can see the medial, the radial, and the ulnar nerve exiting from your cervical spine and going over that first rib and underneath the collarbone. This is a really interesting diagram because you can see the paths in which those nerves take or the parts of the body that they're able to stimulate. So if you have problems with your sciatic nerve or nerves as they would be, you may have pain all the way through the bottom of your feet, down in your gluteus maximus area, the back of your legs, the back of your calves, all the way down into the bottom of your feet. Whereas if you're having some issues with maybe a vertebrae above that or two above that, being your L4, you'll feel that on the outside of your thigh if you have enough impingement on that spinal nerve that it's causing this referred pain being pain that you feel in an area other than is being impacted. So you can see your cervical area coming down in through your hands, as well as the beginning of your thoracic area, and where each one of these nerve pathways lies. So although the term the sciatic nerve is used, it is a number of different nerves that come together and form the fattest nerve that travels the longest distance in your body. So the sciatic nerve starts here between your L5 and your S1, and then there's again grabs these different nerves that are exiting through your sacral area and your coccyx and come together into a large bundle right there underneath or in between the opening of your pelvis, and then it travels down the back of the leg, wraps around to the front, and splits through the knee. And so it is a large fat nerve, and you can see the area in which it exits and where the conjunction of it comes together. One of the reasons why so many people have low back pain or sciatica or that pain in the butt is because when we're sitting for long periods of time, that lower back flattens out. You could do that as you're sitting in your chair. Go ahead and scoot to the forward portion of your chair and take your knees and raise them up higher than your hips, and you lose that curvature in your lower back. And now scoot a little bit forward in your chair and take your knees and drop them down lower than your hips, and you gain that curvature in your lower back. So when you lose that curvature in your lower back, you put a lot of pressure on your spinal discs, which creates the bulging of the disc because of the gelatinous or the movable material of the nucleus, and that can put pressure on your sciatic nerve as well as cause muscle spasm type pressure through the locking up of the muscles.
Varying effects on lumbar disc pressure at various positions. Disc pressure and stress on the lumbar spine is at its lowest when you are lying flat on your back in the supine position. These stresses slightly increase as you move from the supine position to lying on your side. 100 kilograms of pressure is measured on the disc of the lumbar spine when you are standing in the upright position. When leaning forward from the standing position, the pressure increases to 150 kilograms. Holding a load and leaning forward in the standing position causes this pressure to further rise to 220 kilograms. A non-load-bearing position of sitting upright will place 140 kilograms of pressure on the lumbar discs. Leaning forward from this position then raises the pressure to 185 kilograms. And finally, the highest pressure that is placed on the disc of the lumbar spine occurs when you are in the seated position and leaning forward while bearing weight. The idea is to hold this weight closer to the body to reduce the pressure being placed on the discs. Intradiscal pressures associated with the seated positions and postural changes have proven to be greater in comparison to the same position performed while standing. Factors which may contribute to pain or degeneration within the lumbar spine.
There are several potential causes for sciatic nerve pain, but the vast majority of cases are related to disc protrusion and/or contraction of the piriformis muscle. To give you a better idea of how disc protrusions and the piriformis muscle can cause sciatic nerve pain, let's take a look at the anatomy. This is a front view of the lower spine and pelvis, and as you can see, there are nerves that are branching off from the lower spine and also coming out from the sacral area, and these nerve branches join together to form the large sciatic nerve. This is a side view illustration of the lower spine, and it's showing a vertebra with a disc above and below. The disc above is highlighted in red to show that it is protruding and inflamed, while the disc below is just to represent a normal disc. As you can see with the normal disc, there's plenty of space around the nerve. The disc is not pressing up against it, and there's lots of room around that nerve root that is going to eventually join together with other nerves to form the sciatic nerve. As you can see with the protruding disc above, the space around the nerve is narrowed by the disc itself, and in many cases there will also be additional pressure placed on the nerve by inflammatory swelling. So you get the direct pressure of the nerve along with added pressure that's produced by swelling. Now here we see a back view of the lower spine and pelvis, and as you can see, the large sciatic nerve coming off on the left here, and coming off on the right we have it cut off here so you can see the hip capsule that's showing over here. That doesn't have anything to do with sciatica, but I wanted to let you know what that was. Alright, so now let's talk about how the piriformis muscle can affect the sciatic nerve. And the piriformis is a muscle that runs from the sacrum down to the hip joint. And in some cases it will run over the top of the sciatic nerve, as we're showing here. It is actually lying over the top of the sciatic nerve, and it can cause pressure when it lies over the top of the sciatic nerve. In some individuals, the piriformis will actually be underneath the sciatic nerve, as shown here. And usually it doesn't create too many problems in this type of orientation because it doesn't really place any pressure on the nerve. But there is one other configuration that can occur in some individuals, and that is if the sciatic nerve actually goes through the center of the piriformis muscle, as we're showing here, in which case compression or contraction of the piriformis can really create a lot of squeezing on the sciatic nerve and create a lot of symptoms when it does that.
So our spinal muscles, what does this picture show us? What this picture shows us is where you see the white part in through here, and of course in through this part. This is all your tendon attachment. So your tendon is attaching muscle to bone, or it could be ligament attachment, which would be attaching bone to bone. So this is more fibrous than the muscle part of your stabilization muscles, of your core muscles, both front and back. And they're very intricate. You have a layer that's far down in through the body. You have an intermediate layer, and then you have the layer that's closest to your skin. And you can see how they wrap around in different areas. So you don't really have any, not really, but you don't have any at all. Muscle attachment in this, or not muscle in this area. This is all tendon attachment in this area. And here's your muscle. So it really, this picture is here to show you is that your core is stabilized both front and back by the muscles that wrap around like a corset, your oblique muscles, both external and internal, and then you have your erector muscles and rectus muscles, erector muscles that run through the back of the spine, and rectus muscles through the front of the spine, which are your six pack. So what stabilizes your spine is the front of your body and the back of your body. So this is another way to think about it would be with your arm. So if you put your arm and you make a muscle like you were doing a bicep contraction, so you're squeezing your arm, doing a Arnold Schwarzenegger type move, you can feel your bicep getting bigger because your muscle is shortening. And then when you stretch your arm all the way out, pushing it back, doing a tricep contraction, now you can feel your tricep contracting. So when you're halfway there, you're not in complete flexion or complete extension. Both your bicep and your tricep are working. So this is antagonistic and protagonistic pairs, as well as you have stabilizer muscles, which are working in there as well. Well, the same thing happens with our spine. You have both your back muscles on the back of your body, and your front, your abdomen muscles, as well as your side muscles, your oblique muscles, which are all working together to stabilize your core or help to support your spine. So the short story to the long story is that if you can contract your abdomen muscles, do an abdomen contraction, not to suck it in and look thin, but to make them hard and prepare them for the movement before you do a very strong movement like a heavy lifting task, you're increasing your interabdominal pressure and creating more core stability. So you're less likely to injure your spine when you're able to do this. How all the muscles work together to cause that complete stability within the spine. So where will these people hurt at the end of the day? What potential work-related musculoskeletal disorders do you think that they may have? So we're moving to the neck now, and again there's another short video on Moodle. I'm not integrating them into the lecture series here because YouTube kicked them out sometimes because they're copyright. So you can stop and watch them at this time or watch them later. But your head weighs, between 6 and 10 pounds, depending on the size of your head and how much hair you have. And when you take that 10 pounds like a bowling ball and you hold it out at arm's length, such as when you're in a position like this, like your head is leaning forward because you're using your iPad and you're not actually sitting upright with your ears over your shoulders, you're putting a tremendous amount of force on your trapezius muscles and your shoulder muscles to be able to hold your head in that upright position. So neck problems are commonly associated with prolonged static postures where the neck is flexed forward more than 30 degrees. This causes a rather rapid onset of your trapezius area becoming fatigued, as well as the neck muscles themselves, and can cause spinal loading, which would be significant extension of your ligaments that are holding your spine together, because that internal spinal disc is being squeezed down either forward or back, and it has no place, the nucleus has no place to go, so it pushes up against the hard fibrous wall or the ligaments that are holding it in place. So some common disc degeneration type of disorders that you can see either work-related or just because it occurs over time. So you have your normal disc. Your herniated disc is where or prolapsed disc is where the nucleus material actually exits the spinal disc some way, so it breaches that outer hard wall, as opposed to a bulging disc. A bulging disc is where you have a weakness in the wall, but the nucleus material hasn't started to leak out yet. Normal degeneration occurs where your discs get thinner over time, and so you don't have quite the amount of space there or shock absorbing characteristics. Also, when this occurs, if you have too much play or too much motion in your spine, your back may lock up or muscle spasm more, because you don't want instability in your spine, because your body's trying to protect your spinal canal. And then here we have the breaking down of the bone material, degeneration of the bone or the spinal vertebrae, which then goes into the spinal disc itself. And some other pictures of that. So between the combination of the biomechanics lecture and reading materials and spinal work-related musculoskeletal disorders, which include some anatomy, you can see that your posture when you're standing or sitting plays a big role in the amount of stress that's put on your spinal discs and supporting musculature of the back. So the ideal posture is when the forces are evenly distributed, and we call this our neutral posture. And that's where your ears are over your shoulders over your hips over your knees, and your knees over your ankles. And your elbow is in line with your hip as well. And this puts us in the best posture for speed, strength, and endurance, because we can utilize all of our muscles to support our spine, and we're not stretching a muscle group out and then it has the inability to fully contract. Now we say low back and spine, but these injuries occur to the neck as well. Neck injuries are usually not force related, more often posture related, because we do not bear a whole bunch of weight on our neck unless you're wearing some kind of helmet of some kind. But there are a list of spinal disorders, from disc degeneration to neurological problems such as a herniated disc, nerve irritations. You can even get tumors along your nerve roots, muscular or tendon or ligament problems. So it could be tendinitis or ligamentitis. You can have trauma such as acute trauma or cumulative trauma to a muscle, tendon, or ligament. a sprain or strain, which is a tear versus a stress-induced or stress or weakening within the muscles. A muscle spasm is a muscle contraction that is produced uncontrollably. Then there's disorders such as spondylolisthesis, which is when your L5 vertebrae slips forward on your S1 vertebrae. So many different things that can happen in the back to cause disorders. So why is back pain so prevalent? Well, new use, anytime you started something new, you may feel that pain or discomfort in your back or other body parts because your muscles aren't used to it. So for example, if you've never snowboarded and then snowboarded, your body would hurt, feel like you were in a car accident after doing that. So, and then there's misuse, and that's the cumulative effect of a bad body posture over a long period of time. So for example, looking at your tablet with your head canted forward more than 30 degrees and doing it cumulatively over a long period of time. And then overuse is, as opposed to misuse, overuse is overusing one body part. So overusing one side of your body or more muscle group or one muscle group and not creating that muscle balance. So the balance between the bicep and the tricep. So the balance between the erector spinae muscles and your abdomen muscles and your oblique muscles. And then the last one is disuse. And disuse is where it occurs many times when people have pain or discomfort or some type of injury. They tend not to exercise or stretch, and that disuse causes much muscle atrophy as well as a loss of flexibility. Also, of course, as our body ages and tissues undergo changes, some of these changes can reduce our capacity to withstand stress, and we're more likely to be injured. So some possible interventions, rest, changing your risk factors is the biggest one. Prevention is, of course, the best solution or the best insurance against getting hurt. Then next, it's kind of down the line where people step through when they're starting to feel pain or discomfort, although a lot of times they skip that step of changing their risk factors. So rest, then physical therapy, maybe some form of holistic or naturopathic medicine such as acupuncture, over-the-counter medications as well as prescribed medications, steroidal injections to reduce inflammation, cauterizing a bulging disc, for example, so that the nucleus material won't leak out. And then finally to a disc fusion, which you see pictured here, or some form of disc replacement surgery. And a disc fusion that is pictured here, really the screws and the rods are in place to stabilize your spine until the bone graft takes and completely sets that area and makes it immobile. So the screws and the rods are like a cast that goes on, but for many people it never comes off. So here's an example of my husband's first surgery. But why this picture is interesting is you can see in this spot the severe slippage of the L5 vertebrae over the S1 vertebrae. These should be a little bit more lined up. And because he had that forward slippage of his L5, he's no longer lined up with his L4 either. So that's the end of this learning unit. I hope you have enjoyed it, and we'll see you next time. Thank you.